ahead and do it. Okay, I am Renee, Renee Crowgey. I have a master's in clinical psychology. I've been a therapist for 9 years now, and I've been a full-time instructor at University of Portland, and previous to that, Pacific University. So I've been a full-time instructor for 4 years now, just so you know a little bit about my background. And I like to start every talk with just the idea that I am trained. I have been doing this a long time, but I am still a learner. So tonight is me joining with you as you're learning more, hopefully tonight. And I'm also learning more. Research is always growing and changing in the field. So we're always learning something new. For individuals experiencing kind of mental health crises, going through with different kind of symptom presentations, that can change. So mental health, mental wellness to mental illness, that continuum is fluid and always changing. So I say that because I am joining you as a learner too. I want to be on the journey with you. So I say that to say, sure, I'm somewhat of an expert, but I'm also always learning, as we all are. We're all on that journey together. So when I talked to Taylor, she asked me to, oops, let me go ahead and see if I can skip ahead, to kind of go over these topics tonight. We'll go through each one a little bit. And again, if you have questions after each, I'll open it up and just see what questions you may have. And then at the very end, I'm going to be turning it over to another presenter as well to talk a little bit about a treatment option. So tonight we're going to talk briefly about kind of early warning signs for what we would consider mental illness specifically. We're going to talk a little bit about diagnosis, what that looks like, how we come up with what our diagnostic system is and how we diagnose. And then briefly talk about kind of treatment options and how we look at treatment. So it's a little bit of an overview for us for tonight, and we are going to jump right in. That sounds good for everybody. So starting off, some early warning signs. Oops. Okay. So when we think about our mental capabilities and our mental functioning, oftentimes we talk about it being on a continuum. We have kind of our optimal wellness when we're just like really in our prime and everything is kind of working exactly the way we want things to be going. But our mental functioning is always fluctuating. I think most people during the last several months have noticed probably some changes in their mental well-being. So we always think of it kind of as a continuum and a spectrum of where we are, and we're always moving on that spectrum from what we would consider mental illness, which has more impairment in functioning, to our overall mental wellness and kind of optimal functioning. So when we start to look at mental illness and we're starting to think about changes in our mental functioning, typically professionals in the field, we like acronyms, we like cutesy kind of how do we remember things. So one of those that is used in the field with professionals oftentimes are considered to be our 4 Ds. And those 4 Ds are dysfunction, distress, deviance, and danger. And I'm going to go through each of those and just kind of explain a little bit more. But the idea is that when we start to see some of these changes and we start to see some of these kind of early signals, those are indicators that a person might be in a place that they would really benefit from seeking treatment at that time. So our first D is a very kind of individual based one, and it's dysfunction. When we think about a person, typically we all have sort of a baseline level of functioning, and that fluctuates a little, of course, but kind of where we start out and what our baseline is. And as an early warning sign for mental illness, oftentimes you see individuals have some sort of change in that functioning. That baseline in some way for that individual changes just a little bit. It could be in their work life, their home life, in their personal care, and their social life. But you see a baseline, and then often there's a trigger, there's some sort of indicator, and there's a change in that level of functioning. It could be that the person is always going to work on time, they're showing up early, they're always there. And then you notice a change in that level of functioning. You notice that, oh, Sally has been late to work every day progressively for the last 2 or 3 weeks. We're starting to see some sort of change in that level of functioning that we've seen with Sally, or whoever we talk about. We start to see changes for that individual, and it is very specific to that person. Maybe they used to be really interested in playing golf every day, and now they are not wanting to play. Their motivation is changing, their behaviors are changing. You're just seeing some sort of change in that level of functioning. So when we start to see that, that's a little bit of a red flag that maybe there's some more serious issues going on, or there's more that we need to be looking at. So there's dysfunction. Oftentimes for an individual, when they start to notice that in themselves, it can lead to what we call distress. To notice that your motivation has changed significantly, to notice that your mood has changed, and is not just a change in a day or two, but over time you're noticing that. It can lead to very unpleasant or upsetting feelings for a person. It can cause distress. Sometimes that distress is for the individual themselves. It can also lead to and kind of be noted by the people around them. So if family and friends are starting to notice some of these changes, that distress might be from kind of their support system around them too. So you're starting to potentially see changes in level of functioning that could lead to distress for the person or kind of their support system. That's a second kind of early red flag for what we would consider mental illness. Our third kind of D is a deviance. So the first two are specific to that person. Sally has seen a change in functioning and is experiencing some distress or discomfort around it. The third D is deviance, and that's when you're starting to look at the person also within a cultural context. Are we noticing that the presentation of this person is kind of deviant or different from what society would consider normal? I love the quote, so I put it on the slide. The important point is that most psychological disorders are simply extreme expressions of otherwise really normal emotions. So when we think about it, and if we were to each ask ourselves, show of hands, how many of you have ever been a little bit sad before? Has anyone ever been sad? This is also my way to make sure you're still awake out there. I'm just checking in. So we've all been sad. We've all had that, sad days, a couple days, But if we think about deviance, everyone experiences sadness, but that doesn't mean that everyone experiences a depressive disorder. It's just an extreme expression of that really normal sadness that we all feel. In the same way, I don't know for you guys, but during this pandemic, I've noticed some heightened stress. Anybody been stressed in their life at any point, or specifically lately? Yeah, but that doesn't necessarily mean that all of us will be diagnosed with a stress disorder. Maybe it does, but they're just very extreme expressions of really normal aspects of our humanity, right? So when we think about deviance, we're starting to think about, is it an extreme expression maybe because it's more severe? Is it an extreme expression maybe because it's going on for longer and longer days? Society in general says, yeah, you can be sad for a couple days, it's normal. We all have our ups and downs. But if you're noticing that sadness in your mood lasting for 6 months, 7 months, again, it's kind of that normal emotion in a more extreme expression or for a longer period of time. Does that make some sense? Feeling good? Okay, just make sure you're still with me. Our last D, so we have dysfunction, we have distress, where it's deviating in some way from what we kind of consider a societal norm, which is really subjective. If you were to take my class, we'd spend a whole class talking about how subjective that is. But our last D, when we're starting to look at some of the early red flags for mental illness, the last D is potential danger. And I always put that on there, but I say it's our exception. Not everyone with mental illness is dangerous. It's very rare. It's much more common that individuals are not dangerous to themselves or others. But if you start to notice a person's behavior becoming maybe more careless, maybe more confused or hostile, or some of those thoughts of harm to self or others, that's another red flag kind of for early warning signs that we might be looking more towards what we would consider mental illness. So those are kind of our four letters, 4Ds, to start looking at early warning signs. On that note, I was going to see if there might be any questions just in general about our 4Ds. So I'm going to try and get off of screen share again. Sorry, it's a little bulky going back and forth, but I want to make sure that I can see you. Any questions? That was just a really brief one. I think I see, let's see, I think I see a question. If you want to just unmute yourself, if you had a question, and throw it.
Hi, I'm Nicole.
Hey, Nicole.
Hi. What if a person becomes like hostile after they've been mentally ill for a while? What if that's like a later on symptom?
Okay. So I guess it wouldn't really be like an early warning sign maybe at that point, but it's not uncommon to see in the ways that I talked about mental well-being and kind of mental illness changing. The idea that kind of a person is always going to present with a certain, presentation, that can change. That can change over time. That can change based on kind of their external environment and triggers and what's going on. So it's not uncommon to kind of see that hostility, maybe anger and frustration arise later on, not one of the very first warning signs, but kind of later into the progression of showing symptoms. Does that make sense?
Yeah, but mine was more like an uncontrollable.
Like uncontrollable, like hostility and anger?
No, I wasn't angry. I just acted hostile. Like it was not. It was like not me.
Okay. So you were noticing that kind of that wasn't initially in the way that you were feeling, but over time that hostility kind of came out more and more, and you were feeling it more.
Yeah. Yeah, like I acted out, but I wasn't choosing to. I just did it.
Yeah, so you were just kind of behaving, and there wasn't really a thought behind it leading to that hostility. Is that what you're?
Yeah.
Yeah, and that's, each person's experience of, kind of mental illness is very different. And so to have hostility come on later and without that kind of thought process behind it, it's common in the sense that all symptoms are uncommon, and it doesn't ever follow an exact pattern. Does that kind of answer your question a little bit, Nicole? I think.
Yeah, it did.
Okay,
thank you.
Sorry, it muted again. Okay. Thank you for that. Any other questions for me before we keep going?
Renee, we have one question in the chat box. Is there any good way to discern between mental health and substance use?
I would say, and I actually might let Dr. Horey answer that a little bit more from Active Recovery. He's probably going to talk a little bit more and could address that maybe towards the end. Do you want me to throw it to you now, Jonathan, or do you want me to jump in on it?
No, I'm happy to. I mean,
yeah, it's your wheelhouse, so I was going to let you run.
So I'm an addiction psychiatrist. So it can be very difficult to distinguish between symptoms of substance use and mental illness because they can mimic each other quite a bit. I think in general, we tend to say that if someone's using substances that at a level that's abusive or dependent, we tend to think about the symptoms first as results of substance use, because that's something we can address more acutely, right? And helping the person not use. Not that that's easy, but it is something that we can acutely identify. And usually that's sussed out by the history, right? So if someone's had symptoms for a long period and the substance use has come along later, that tends to mean they're using the substances to medicate. Whereas, the other way around, if they weren't having symptoms and then they start using substances and then these symptoms come up. So that's one way we can tell. But the truth is they mimic each other quite a bit. And especially if someone's had both mental illness and substance use for a long period, the important thing is that you get treated for both. One of the fallacies that's been in mental health for a long time is that, you should take care of one before the other. And that just doesn't make any sense. They're usually in most cases, both are intertwined. So you have to treat both. And again, a good history is probably the most important thing to know what to target and how aggressively, because it really does depend.
I think maybe there's another question. Nicole, do you have another question?
Yeah, I have another question. Sorry.
Go for it.
This question is it Horey? Horey is the name?
Yes, Jonathan.
Yeah,
Um,
Dr. Horey.
if someone has started their mental illness with meth-induced psychosis and it never went away, and now that person is treating with Adderall, is that gonna make the damage worse?
Yeah, it's tough to talk about individuals, right, without knowing the whole history. What I would say generally is that people who've had psychosis from methamphetamine, it's usually not a permanent state. It certainly can be in extreme cases, but not usually. I would say in general, Adderall is not something I would generally prescribe people who have methamphetamine use, especially acute, but even longer term, because it's it acts in a similar way, and there's a higher potential for abuse. So
Okay.
that's probably more generally what I would say about it.
Okay, thank you.
Yep.
Alrighty, I'm gonna hop back in just to kind of keep things going, but if you do have other questions, pop them in the chat, or we can take more at the end as well, but just to kind of stay with the time that Taylor's given us, we'll hop back over to our screen share again. Sorry, and then, sorry, it's a little bit bulky, but we'll get it going. So if you are noticing in either yourself or someone you care about, a friend, a loved one, etc., if you're starting to see kind of a change in their level of functioning, it's causing distress for them or yourself, or you're noticing it's maybe starting to deviate a little bit from kind of what would be considered more normative, or if there is thought of self-harm or any sort of a danger piece to it, what do you do? For yourself, I always like to tell people that can be really scary. It can be scary and overwhelming to start noticing those changes. But knowing that you're not alone is a huge piece of it. Knowing that 1 in 5 adults in the United States will experience mental illness at some point in their lives. So if you think about, the number of people in this room, we're talking a significant portion, 1 in every 5. So I think it's always helpful to know you're not alone, even though it might feel that way and it might be isolating or, really scary to a lot of people. But know that you're not alone and that there are people who are here to help. Taking those first steps to get help in place is hard. It's a really hard and brave step. But it can be so beneficial for you as an individual or for the person you care about. So if you notice those changes in yourself, know that you're not alone. It's the first piece. If you start noticing changes in someone you care about, what can you do? I always tell family and friends that one of the best things they can do for someone you care about is simply to listen. People don't always need advice. They don't need to be told what to do, but just to have someone they care about listening to them is a huge help, to help normalize and validate what they're going through, their experience, their feelings. And then asking, how can I support you? Let the person lead you. Do they need help finding a provider, a professional to reach out to? Do they need help getting to an appointment or setting that appointment? And really letting the person lead, giving them as much control as they can take over, seeking their own help. So that's kind of the transition into when you seek help, what does that look like? So when you go to see a professional, trained professionals kind of follow 3 steps in terms of our clinical practitioner model. They first want to get to know you. They want to understand what's been going on. They'll tell you about confidentiality and all of those pieces, but then they're going to sit and usually talk with you, ask you questions, really try and understand what's been going on for an individual and what the experience has been like. How long have you been feeling this way? How long have you felt these symptoms? To really start understanding the individual. From there, they're going to start looking to see if the symptoms that you or your loved one or the person you care about, what they're presenting with matches what we know about our disorders. And we'll talk a little more about that, looking at the DSM, and then from there, seeing what treatments have evidence to back them as the treatment for that. So when we talk about diagnosis, again, we're starting to match. This person's telling me, oh, they are having trouble getting out of bed every day. They have a low mood. They're feeling sad. They're feeling withdrawn. They're isolating. They haven't showered in 2 weeks. Here are kind of what's been going on in their world. Do we know anything? Have we seen this presentation before? And in doing that, we're looking at a diagnosis. We're looking to see if that pattern is similar to something that we've studied and that we understand already. So therefore, we can apply what we know about the disorder to then helping that person. That's what diagnosis is. In the United States, we use that's probably more information than you want on this slide, but we use what's called the DSM. It's our Diagnostic and Statistical Manual of Mental Disorders. Started in 1883. We're currently on our 5th edition of it. It came out in 2013. And it has roughly 500 mental illnesses covered within the DSM-5. The DSM is basically kind of a checkbox list of criteria for each of our disorders. It looks like this is a slide example from the DSM-5 of major depressive disorder. Has the person experienced 5 or more symptoms in a 2-week period? And it lists them out, some of the symptoms that we know to be common for major depression. The DSM, however, doesn't tell us what to treat or how to treat, but it's just trying to give us a language of understanding for symptom presentation. In the field, there has been a long debate about diagnosis, kind of the pros and cons, what's the good and the bad of using this system. If you were to take a class with me, you would write a whole paper and do a debate on pros and cons, but I'll give you the cliff notes. When we think about diagnosis and using the DSM and that criteria, one of the major pros is trying to find a common language. So if you go to see a therapist and then you go to see your general practitioner, your doctor, they're using the same language to talk about the symptoms that you're presenting with. So it gives a common language, especially amongst providers. There's also benefit that if we have individuals with similar presentation, we can then utilize that to research and understand better how to treat those symptoms and how to ultimately help a person. Another kind of benefit for some people with symptom presentation can be really scary and isolating. I feel like I'm the only one that feels this way, like what's going on? So to speak with a professional and understand that, oh, your symptoms actually meet criteria for this disorder, that can give a lot of validation and relief and also understanding for individuals. So those are some of the benefits of diagnosis and kind of using our DSM system. Some of the cons, it can feel for some that it's a label. They've been labeled as schizophrenic. They've been labeled as, and we understand, of course, that there are also stigmas around that label. There's also some drawbacks that it could lead to what we call like a self-fulfilling prophecy. The idea that understanding more, I tell all of my students in abnormal psych that I teach, don't diagnose yourself. You will diagnose yourself with every disorder we cover this whole semester. This idea, as you learn more, sometimes there's a tendency to kind of diagnose into other aspects as well. So that's kind of pros and cons of using our system of diagnostics and using diagnosis. But a major benefit is that it allows for research to try and understand how to better treat and help individuals. I'm checking time just to make sure, Taylor. I might keep going so that we could do questions at the end. Is that okay for you? I don't want to go over my time window. So, but yeah, so the idea, if you're noticing warning signs, you're noticing changes, you're seeking out a helping professional, you're looking for a professional to help. Treatment in general has a person coming in that's wanting help. It has a helper. It could be a therapist, psychiatrist, psychologist, clinician, counselor, whoever it might be. And there's an interaction between the two to try and see change for the person to not feel the way they do when they come in, when they leave. When we look at treatment, treatment is oftentimes based on the specific disorder as well as what we know is empirically supported for that treatment. Again, the DSM gives us each mental disorder, mental illness, and criteria for it, but tells nothing about how to treat. So treatment is largely based on the research that's being done. What do we know helps with this disorder? As well as the therapist approach, kind of theoretical training that they've been trained in. And so the clinician utilizing that initial assessment to really understand what's going on is then ultimately going to also impact treatment and understanding what's going to best be able to help an individual. So in the field, there's lots of treatment options and perspectives. There's cognitive therapy that looks at thought patterns. If the person's having kind of thought patterns that aren't helping in their day in and day out life, can we challenge those with cognitive therapy to change those to more helpful patterns? Behavioral treatment looks at changing behaviors themselves. For individuals with an eating disorder, there's a behavior that you're wanting to see changed over time. So behavioral therapy targets specifically those behaviors and how to change them. Humanistic and existential therapy look at kind of like your meaning in life and what you're able to get out of it, and how can we build more meaning into a person's existence. Our sociocultural model looks at kind of family systems and how you function in the world around you, and how society impacts you, and how we can better support an individual in their kind of cultural and social circles. Psychoanalytic looks a lot at past history and trauma, and then our biological perspective looks at more of our genetics and neurotransmitters and what's going on within us in order to best be able to help. Most therapists identify as eclectic, meaning they use pieces from all of these models, and we oftentimes use a biopsychosocial approach, knowing that there are often genetic pieces and there's biological aspects that impact our presentation, as well as psychological and social. So looking at all of that to give the best treatment we can for an individual. At this point, that was kind of a long spiel, but at this point, I am going to turn it over. Dr. Jonathan Horey, who you've met a few moments ago, is from Active Recovery and is going to be talking a little bit further about a type of treatment. Again, there's several different kind of theories, but he's going to be speaking further at this point. Turning it over.
All right. Thank you, Renee. I appreciate that, and appreciate the introduction. I'm going to share my screen here. All right. Are we good there? Excellent. Okay. So I'm going to talk today about a specific kind of treatment that's newer, especially here on the West Coast. It's been around, actually, FDA cleared since 2008, but is a bit newer out in our area here in the Northwest. First, just a little about me. I'm a psychiatrist. As I said, I have especially in addiction, and then also in transcranial magnetic stimulation. I have a private practice in addition to running these TMS clinics. So where I use medications, I'm also a psychotherapist. As Renee was talking about, I'm more of a psychodynamic or psychoanalytic psychotherapist. So I think all of these different modalities can be really useful. TMS is one that's particularly helpful for people with treatment-resistant depression. And so that's what we're going to talk about a little more today. But TMS for me, I trained in New York at Columbia University, and they did a lot of the early trials on TMS. So even though I wasn't doing TMS myself, I had a lot of colleagues that were doing the research, and I also had patients that were getting TMS. So when I came out to Portland about 6 years ago, I looked around for people who were doing TMS because I had patients whose depression wasn't responding to medications and psychotherapy, and discovered that there were no options for most people. There was one place doing it. Kaiser is a health system most of you are probably familiar with, and they have a TMS division, but that was it. So I started this out basically because I wanted to use it for my patients because I knew how well it worked. So speaking of that, I'm not going to get into the specific physics too much of how TMS works, but you can see this shameless picture of me applying TMS to someone. And we use this because we don't have to pay for this picture. That's why we're using this one. But the way TMS works, and the best way I think to think about it if you're not familiar with it, is that it's similar to an MRI. So most people have gotten MRIs, and with MRIs, you're using electromagnetism to take pictures of different parts of the body. And the way that works in a broad sense is that different tissues in the body have different concentrations of water molecules. And so the magnets help measure the density of that, so that the pictures can be taken. TMS is similar in the sense that it's the very same technology. In fact, the strength of the magnet's actually fairly similar. But as you can see up here, actually, I'm going to see if I can get my pointer going here. There we go. So you can see here, this is the magnet here. And it's, as you can see, it's right on top of this person's skull. And so the big difference with TMS is that rather than just taking pictures using magnets, we're actually stimulating the brain. And the reason we do that is that we want to target specific areas in the brain that we know aren't working as well in patients with depression. And the long, fancier name for that is the left dorsolateral prefrontal cortex. This is an area in the brain that is particularly important for linking up our frontal lobes, which is where our executive planning and those kind of things happen. And then our limbic system, which is the emotional part emotional processing part of our brain. And it's thought that this particular part of the brain is not working as fast or as regular as it should. So again, the physics of it is you can, if you're so interested, you can look up Faraday's law. For those who took physics in high school, you might remember that. But essentially, it's the changing field in an electrical circuit will induce a magnetic field, and that field gets transmitted from this magnet here across the scalp and skull. It's painless because there's no electricity running there. It's just magnetic force. So it doesn't stimulate the scalp and skull the way it would if it were direct electricity. But then as it hits these nerves in the brain, it gets turned back into electricity and stimulates the neurons in the brain. So let's see. Oh, too fast. There we go. So the TMS is really developed for treatment-resistant depression, and treatment-resistant depression can be defined in many different ways. But essentially, it's the failure of standard treatments to produce response, which is generally defined as about a 50% improvement in symptoms, or remission, which is a more significant reduction, depending on the scale you're using. And about 30 to 50% of patients who have depression can be classified as having treatment-resistant depression. Unfortunately, antidepressants don't work as often as we'd like them to. And this is important because about a third of patients with treatment-resistant depression will attempt suicide, which is about double the rate of those who do respond to treatment. The FDA guidelines for TMS are that you have to have at least one failed trial of an antidepressant and one failed trial of psychotherapy. And failure can be either it just didn't work, or there were intolerable side effects in the case of medications. Most commercial insurance plans, so that's basically anything outside of Medicare, require 2 to 4 antidepressants. It varies by the insurance plan. It isn't really based in science, but it's what they require. So as far as evidence for TMS, there's a lot of different studies I can show you, but this one I like because it's sort of a real life trial. So they did it in an actual clinic with patients coming to the clinic. And essentially what you see is that for these patients who had treatment resistance, overall about 58% had a response. And again, the response is that they had a 50% or better improvement in their depression symptoms, and about 37% had remission. And then the other interesting thing about TMS and why it was sort of exciting when it came on is that the difference between those with low treatment resistance, which in this study I believe was defined as 2 or less medication trials, and high treatment resistance, was not extremely significant. So it was about as effective for those with high treatment as it was for low. And then this study by Dunner in 2014 followed patients for about a year after they finished treatment. And what you see here is that at the end of this 12-month period, most patients kept their gains, both in terms of responses and remission. So in general, the nice thing about TMS is, unlike a lot of other treatments, it tends to be durable. So Some of these patients continued on medications. Some of them even got TMS, so what we call booster sessions during the year, but most were either not on meds or continued just on their medications. They weren't getting TMS during this period. So it shows you that it's a pretty durable response, and that's another real benefit of TMS. A lot of times I get questions about, well, how is it different than ECT, which is a good question. And without going into too many of the technical details, the basics of it is that ECT, which you can see here by our guy lying on the gurney here, ECT is essentially a direct current. So you're hooking electrodes up to the patient's head, and the goal of ECT is to cause a seizure. And that seizure resets the brain's neurochemical balance and is actually a very effective treatment for many types of severe depression. Obviously, it's not what we use initially for patients or even second line, but for patients who have severe depression, especially those who have psychotic symptoms, who are acutely suicidal, and by that I mean that they're imminently suicidal, it's extremely effective. And then for patients who have what's called catatonia, which is sort of a symptoms where they have real difficulty moving or speaking. But it requires anesthesia because if you were awake when you got this electricity, it would hurt. It is not like One Flew Over the Cuckoo's Nest, at least not anymore. The anesthesia is quite good. You don't have a lot of shaking because they give a neuromuscular blocker. And I've certainly had many patients who have a great response to this, but it is a much more invasive and potentially side effect filled procedure. So the difference, as I said before, is that with TMS, magnetic fields pass painlessly through the scalp and skull. And that way we don't need anesthesia. There's no recovery time, things like that. So, and I can answer more questions about that obviously later. But so what does TMS look like? The basic course of TMS is that our first treatment is a mapping session, and mapping session essentially is where we're trying to get the right hand to twitch. We want it to kind of do that when we stimulate your left motor cortex, and we do that because we use it as a proxy for how much we're going to stimulate the area we're actually aiming for, which, as I said, is this left dorsolateral prefrontal cortex. We use this because we wouldn't know how much power to give if we didn't use this, because this doesn't have any direct output. Thankfully, the distance between the motor cortex and this area of the brain is actually very constant in most people, so we can measure it fairly accurately. So that takes about an hour. The subsequent treatments are 20 minutes. It's 5 days a week for 6 weeks. And I always say this is the sort of the hardest part. If you're going to find a hard part about TMS, is that you have to come in 5 days a week for 6 weeks. Again, the sessions are only 20 minutes, but for people that are depressed, sometimes it's hard to get out and come in. I will say that most of our patients who can get here, they really end up not having too much of a problem coming in. We don't have very many people that drop out or don't show up. And most patients see improvement between 3 and 5 weeks. Sometimes we can extend treatment if someone, for example, doesn't get better and towards the end of treatment, we can usually extend it. Insurance will usually pay for that. And that leads me to talk about insurance, which the great thing about TMS is that insurance does cover it. So Medicare, Medicaid, not in all states, but in Oregon, Medicaid does cover it, and almost all commercial insurance plans. And so that's a really nice thing, is the access is good now. Now, 3.5 years ago when I started this, it wasn't that good, but it is now. Just briefly, some other disorders that can be treated with TMS. Obsessive compulsive disorder actually does have an FDA indication. It's not yet covered by insurance, except in very special circumstances. It will probably be soon, I would hope in the next year, that we'll have that as a paid for indication by insurance. And then there's a lot of other indications that have good, fair to good, I guess is what I should say, evidence, but not FDA indicated and certainly not covered by insurance. So just briefly on the side effects, because that's important. The one we worry about the most is seizure. So unlike ECT, we actually don't want to cause a seizure with TMS. As you can see, it's quite rare. And unless someone has a predisposition to seizures for whatever reason, either because they have epilepsy or because they're drinking excessively, it's very unlikely. There is a sort of theoretical risk of hearing damage, but the actual threat to the eardrums and the inner ear is pretty low. We always use earplugs for patients anyway, but that really brings it down significantly. Some people, the syncope is, for those who don't know that word, it's when you stand up and faint. This can happen after usually the first session. And my bias is that's probably because people are anxious when they get TMS. And so they get a kind of that adrenaline dump. And then after the session, they stand up and they feel a little woozy. So we've actually never had a patient syncopize fully. We've had patients feel a little lightheaded. But again, that's usually the first couple sessions and then they do okay. And the important thing to know is that a very small percentage of patients actually discontinue because of side effects. It's overall pretty well tolerated. The more common side effects are scalp discomfort and headache. Those happen basically because we're stimulating the muscles on the top of the head. They react to that magnetic force, and so they twitch. And so it kind of feels like someone's patting on the head like that. I've had it done myself because I wanted to see what it felt like. And the best I can describe it is that it's weird, and it's a little annoying initially, but it's not painful. If it's ever painful for people, we adjust it so it's not. It's really more just getting used to the sensation. And then after the first session, first couple of sessions, usually people have no problem. They sit and watch TV or read or on their phone. It's a pretty low-key treatment. So as I said, some lightheadedness. The important thing also, again, this is very different than ECT. There's no effect on memory. And the reason for that is essentially because we're targeting a very specific area of the brain. To affect memory, you really have to affect a lot of areas of the brain. But targeting it, which is what TMS does, there's essentially no chance that you're going to have problems with memory. So I'll stop there. I'll stop sharing my screen. And I'm happy to take questions, but maybe I'll turn it back over to you, Taylor.
Yeah, sure. We did have a couple questions. I think this one was actually from earlier, so we might have both of you guys answering some of these. Is another item to consider that the marijuana types can fluctuate from an upper to a downer. In my experience, PTs that smoked sativa strains can manifest attributes similar to methamphetamine.
That'd be patients.
Patients, yeah.
Oh, okay.
Yeah, no, the marijuana that's out there today is not your father or grandfather's grass. I mean, it's a pretty potent, or there can be a lot of potent strains, and you're absolutely right that, you know, sativa strains versus the other kinds of strains can be very different. With marijuana, generally, you know, the percentage of THC matters the most, and of course, with more THC, you get more of a high, but you're also risking some of the other downsides of marijuana, including anxiety and even paranoia and psychosis in rare situations. So it's important to know that. And I would say, you know, in general with patients, it's important to talk to them about the percentage of THC they're using. Those that have more of the cannabidiol or CBD that has become more popular, that has less of that effect. And so that helps people who have more anxiety when they're smoking. More CBD is generally better for that.
Thank you.
That answer your question. Awesome. Okay, and then someone asked about other types of therapy, which I know Renee spoke to briefly in the treatment section. Did we have any specific questions about that slide? I'm going to send all these slides to you guys. They'll also be available on our website as well, on the NAMI Multnomah website. But if you guys have any specific questions.
I can also
Renee,
yeah, I can jump back and just give a little bit more on that. I didn't really know what people might want to know about, so it was pretty vague. But as Jonathan's been talking about, we definitely in treatment look at our biological aspects. We look at what's going on internally, genetics, neurotransmitters within a person. And so talking about medications, ECT, TMS is all looking at that biological piece. On the other side, we have more of our psychological therapies. Cognitive behavioral therapy is one of the leading in terms of effectiveness for the majority of clinical disorders. But there's also other approaches. I think, Jonathan, you mentioned psychodynamic as kind of your training. I don't want to put words in your mouth, but
yeah, no, that's right.
Yeah, so there's different approaches that kind of target different aspects of presentation of symptoms. And the last is then more of a sociocultural, looking at strengthening family systems, relationships around a person as well. So those are kind of the three tenets of treatment. And individuals, each treatment might look significantly different, kind of pulling from different aspects of that. I don't know if that helped or gave any more information. I'm not sure.
Awesome, thank you. Will you talk a little about anosognosia, lack of insight that 50% of folks with bipolar or schizophrenia have? How do you get them to accept treatment if someone doesn't think that they're sick?
Yeah, so anosognosia is essentially you're not aware of your own diagnosis is maybe the best way to put that. That is a difficult thing with a lot of mental illnesses and addiction, maybe particularly. And there's no easy way of going about that. I think probably the most effective thing for that is establishing relationships, especially with professionals who will work with the patient and not expect perfection. There's a great AA saying, progress not perfection, that I like, and that's certainly true with chronic mental illnesses because they're not going anywhere, and it's unfortunate because we don't treat people who have heart failure with the kind of spite that we often do people with mental illness. I worked on a cardiology floor when I was an intern, and we'd have people come in every few months with their lungs filled up with fluid because they ate out at the cart. Sorry, that's a New York reference, the food carts. And they wouldn't follow their diet, and so but we give them the drugs that help take the water off and send them on their way. We're not as kind to people with mental illness who don't want to take their meds because they make them feel terrible, or so the important thing there is to realize that mental illness affects the brain. The brain is the thing that you need in order to fight your mental illness. So it's a really difficult situation a lot of people with chronic and especially severe mental illness are in. So they need allies. They need family and friends, and they need professionals who are going to stick with and work them. So I think helping people with mental illness realize that they're going to have to deal with this for the most of the time in these severe cases for the rest of their lives. And so finding people that they find helpful, but not giving up. There's a great book for those who are interested. I'm sure many of you have read this, for bipolar disorder she's a PhD psychologist, and she has bipolar disorder herself, and it's called An Unquiet Mind. And she talks a lot about how it took a long time for her to work with her psychiatrist to become comfortable with taking medications. And until she could really trust him, it was hard. And it was hard even when, with all the education experience she has. So I think a lot of it is just accepting that it's difficult to have a chronic illness, period. It's difficult for people with diabetes, high blood pressure, anything. Mental illness is really no different. It's just that it has the extra difficulty of the organ that's affected is the one that you need to manage it. So in the end, it's support. You need support.
I think that actually perfectly. Oh, sorry, Renee. Go ahead.
Can we jump to the next question? Because I think that.
Yeah. Exactly. The next question is, where is peer-driven services stand with clinicians? Renee, go ahead.
And I can't speak for all clinicians, but I think, as Jonathan said, the more supports for me as a clinician, the more supports my clients and patients can have, I want to utilize all of them. And that might not be the mindset of every clinician, but I think for most people, they would agree the more support around, the better the individual's support system, the better the prognosis is for that person. So bring on all of the peer-driven services, for me anyway.
Yeah, I think that's true. And I think it's, especially true in addiction where, AA and other models, not for everyone, but, I usually talk to patients about it as free treatment because if there's the saying in AA, works if you work it. And I think for individuals for whom it, connects, just like not all therapists work for individuals, not all peer-driven services work. But I think trying them doesn't cost you anything, both literally and figuratively. So yeah, I'm a big supporter of that.
And as most of you know, on this call, NAMI is all peer-delivered services. So our NAMI peer-to-peer class, our NAMI connections groups that are currently happening right now, I'll send you guys information. We actually have a peer-to-peer class coming up next week. And it's great to make connections. There's also DBSA, which is a really amazing peer support group as well. I myself am a peer, and I have gotten a lot of help from support groups and things like that. And it helps support your treatment clinically as well, I would say. And I actually kind of want to take the next question briefly. Could you speak to options to helping a teen to get help if they are unwilling to address their issues with a therapist? So in my role at NAMI, I speak to my experience with mental health growing up as, when I was a teenager. And I definitely think that's something that I wish I knew then, that I know now, is that therapists are not a one-size-fits-all model. Like, I know that we know this, right? But we need to just be reminded sometimes. I literally had a therapist when I was 16 or 17. When I explained a panic attack to them, they asked me if I had been worshiping the devil. And so I was completely turned off from therapy for like almost 10 years. I self-medicated. I went down a bad path, and I just think that, I don't know if this answers the question, but I do think that, it's not a one-size-fits-all with therapists and treatments in general. And Renee and Dr. Horey, if you want to add to that.
Yeah, I can jump in. I have worked primarily with teenagers, so I would also agree. If there's any possibility of having a teen see a second therapist, it's not uncommon, unfortunately, for people to maybe have kind of these weird and awful, like, as a therapist, I'm like, no, like, to have a person kind of turned off from therapy, which I'm super biased, but I think can help so many people. So maybe trying a second approach. There's also, based into school systems, there's supports in place too with counselors and social workers oftentimes on the ground there. I've contracted into schools before, and teenagers that were not really wanting to come see me because I was a therapist, sometimes had more comfort with some of the systems already in place with people that they would see in the school regularly. It felt like a less threatening first step. So if you can ever utilize kind of social workers, counselors within school systems that are already there, that's another option. And then also kind of peer-to-peer supports, utilizing organizations like NAMI and the services available, as well as there are like great Instagram accounts and like ways for teens to connect with others experiencing similar kind of symptoms to gain support, hopefully in really healthy ways, that maybe a teenager might be more willing to access and utilize. Jonathan?
Yeah, I mean, not much to add except to say that, oftentimes I'll talk to patients about how, you wouldn't, if you had something wrong with your heart and you went to a cardiologist and they gave you some crazy thing that didn't make any sense to you, you wouldn't just give up. You'd go to another cardiologist, right? So again, it's all about trying to recognize that when you have symptoms of mental illness, whether that's depression, anxiety, or anything else, you don't stop until you get the answer that makes sense to you and that works. It's easy to give up on ourselves and on others when it comes to mental illness because there's such a stigma attached to it. But we don't do that in any other part of medicine. It's not acceptable in medicine for someone to walk around with heart failure that's unexplained. We don't just throw that away. And the same should be true with symptoms of mental illness. And it's very hard if you're alone in that to remember that. So reaching out to peers, friends, family, whatever, keep going until you find what you get, because most of the time in most mental illnesses, things will get better. Most mental illnesses are treatable.
And I should have said this as well. On our website, NAMI-Multnomah.org/resources, we have a program at NAMI Multnomah called Ending the Silence, where we go into middle schools and high schools and talk, like, young adults share their stories, connect with the youth. And I put together a resource list specifically for teens and youth, just to share at those presentations, because sometimes teenagers don't want to be told what to do by their parents. They want to do it on their own. So if you just give them the opportunity to look at those resources, and then they have the initiative to get involved with some of those support groups and things like that. So I hope that answers your question.
I'd say
We're actually
actually not only kids but adults don't like being told what to do either, and so often that's helpful anyway, right? To give things,
that's true.
more suggestions, because no one likes to be told what to do, especially when it comes to your health. So suggestions are great.
Absolutely. So we're like right at 7 o'clock, which is amazing. I don't see any other questions in the chat box. If anyone has any other questions, please feel free to ask them still. We can wait around for a couple minutes, but I want to thank Renee and Jonathan for being here and presenting for us. You guys were amazing. And I want to thank all of you guys in the audience for being here and caring about this. Because we do know that there is stigma, and we as a group are fighting that because there shouldn't be. So thank you guys so much for being here.
Thank you so much.
I will email all of you, of course. I'll email all of you the PowerPoint slides.
Thanks, Taylor. Appreciate it.
Thank you.
Guys.
Yeah, thank you so much. Okay.
I wish we had some like signing out music, like some elevator music or something. Awesome.